I want to try and set some context on top of what Swami said. Because I've worked in healthcare all these years, I get a lot of calls from my friends every day with lots of questions. The easy ones tend to be, we're all at an age where we're retiring from work, and the easy one is, my company provided cover will no longer be valid. What insurance should I get? This is a very common question, easy to answer. Another easy question that comes my way is that, my claim is taking too long to process. Can you please help speed it up? Or that I want to see a specialist. Very easy to answer. The not so easy is claim related, where the insurer is disallowing parts of my claim. What should I do? Or I want to see a GP. That's not easy to answer today. The difficult ones, of course, are how do I get insurance coverage for my domestic worker? That's not at all easy to answer today. The tough one, of course, is how do I get medical treatment for my domestic worker? Because I get the occasional impossible to answer question, which is that I've just been diagnosed with a medical condition. How do I get insurance to cover that? Now, like Swami said, we are all the fortunate few that we can access healthcare when we need it. But 90% of India's population struggles with that. Now, on the one side, we have the government increasing the supply of doctors. So today's budget talks about government planning to add 10,000 more medical seats in the current year, which adds to the already 100,000 seats that we have. Yet, we struggle when we have to go and find a general practitioner. So, in the book, we've talked about ways to change this approach, and I want to get started with this discussion with a question to Professor Subodh. Now, Swami talked about the need to change from a primary care to a comprehensive care model. As someone who's working closely with the government on the Ayushman Bharat program capacity building, please tell us about how do you see this change happening from primary care as it exists today. The government has set at all 100,000 health and the primary care centers are going to get transformed into health and wellness centers. How do you see this change to comprehensive care happening?
Thank you, Srivathsan ji and Swami ji, and also my co-panelists. First of all, on behalf of ASCI, thank you for hosting, or I would say being part of this event. It's an honor to have you all here. And I don't know, it may be coincidental that being the budget today, you have chose this date as for discussion, because at the end of the day, everybody as healthcare professional, we are actually asking whether the budget which was presented today, how is it going to contribute to the UHC? I think tomorrow newspapers are going to talk about that. But let me just start with sort of premise to answer your question. We have this preconceived notion that I'm sure with many, that UHC, I think Swamiji also mentioned this, UHC means insurance. Like whether we can get everybody under insurance, then I think the country can get in universal health coverage. And that actually is a misnomer. So the first thing is, you don't need everybody to go in for surgeries. You need to handle your primary care much better. And I think a couple of days before, I think we had this discussion with the Union Health Secretary, previous Health Secretary, she said it was very difficult to convince the government to even start the health and wellness center, because everybody said, let there be national state schemes, let me also have a national scheme, which will be more of a tertiary care. But then I think some sense prevailed and said, look, it is not always the tertiary care, you also need to strengthen your primary care. And that is when the whole discussion about health and wellness center came. So the starting point is, yes, you need your primary care very, very strongly. And I think COVID has also told us, and it's something which we all know, that the health system strengthening, whichever states had a very strong primary care system, could actually handle the crisis much better. So your important that you have to have a very strong primary care, but then your problems also are there. What happens to your manpower there? Whether now there has been debates, whether when you go, and everybody knows this, India is a very vast country. We can't at some point compare only like India with Canada sometimes, because you also need to see, you can compare maybe Kerala with Canada, you may get a better indicator. But you look at this from a regional variation, you don't have your manpower, then whether you are follow your IPHS standards, whether you are for infrastructure, then, and there are a lot of questions now, whether you actually need a doctor there, whether you can't a nurse just handle it, because right now the pharmacists are handling it. So a lot of debates in primary care actually happening, and now we are adding more and more services because we want to make it much more comprehensive healthcare services. So that way the model is actually good, and this is not the first time we have actually had it. Because I always talk as an academic institute, we all should look at what others have done. So I think from 2012, if I remember, I think the University of East London, I think one of our faculty who used to work here also and also with XSL, Professor Malarao started one interesting initiative called as the piloting of UHC in a district in Kerala and one to two villages. So what she tried to do was, let us support the primary healthcare center, let's see what actually happens. The problem why everybody is now, like I think your book also suggests that 50% of people in AIMS or JIPMER or Sanjay Gandhi, 50% of people coming for primary care or preventive care, they have no business there. They should be actually be moving from a sort of a referral. But what the problem is that there is no sort of a trust factor in the rural areas. So they opened up a village, they said let's give them awareness, let's not just bring only healthcare. This I'm talking about 2012, much before the health policy, much before Ayushman Bharat. And then 2012 they said let's do it in a district, let's give them awareness, let's bring the other sectors, water, nutrition, the other factors, give them awareness. And they clearly showed that after a point of time, there was a sort of awareness created, people started using the government facilities a little more. And then government of Kerala subsequently started their Arthur mission, which is actually a UHC model in 2015. So which is actually again a model which is to support, and they scaled it to the entire state, which subsequently in 2018 became more of a health and wellness center and more of a sort of a developed model now what we see. But again when we look at this, like for example today's budget, now this is where you have to be a little, when you talk about comprehensive care, you need to be a little careful. Last year it was all about dialysis centers. Every district should have a dialysis. Today they are saying every center should have a daycare center. Cancer daycare center. Now what happens if you are a terminally ill patient? What happens to a palliative care? So there are a lot of offshoots to this. So the point here is in a primary care, when you come to a comprehensive is, your quality should be absolutely fine. Even if you are in the rural areas, people should go actually. So one of the things, some evaluations which have happened in the PhD, in Arthur mission, the study have shown, the out-of-pocket expenditure, people have come down because they don't need to go to a higher facility, and secondly, the utilization in the government facility, which was around 15-20%, has gone up to 30-40%. So like the rightly said, people should get into the trust of going into the government facility.
On that point, one of the things that we've talked about is to have technology-enabled frontline healthcare workers. Okay? The government actually launched the ASHA program many years ago. We have more than 1 million ASHA workers who are today largely doing other things because the government doesn't pay them a salary. And therefore, they are typically trying to find work with other organizations who pay them on a project basis. What can be done to make that entire resource pool? Now, you talked about the fact that today's budget talks about, cancer daycare centers. Okay, we have yet to see the government come and provide a budgetary support to pay the ASHA workers a salary and to train them. So, could you talk us a bit about that?
Again, see, ASHA workers or the accredited social health activists were typically a volunteer workers. They were supposed to come from the village to take them to a sort of a volunteer position. So in Tamil Nadu we call it link workers. The idea was supposed to be a sort of a volunteer. They should be part of the community. But later, they were paid incentives based on whatever they. But then I think states like, Orissa, we have seen this, or even in Telangana, we have seen people asking, put us into a sort of a salaried pool. But I have to tell you that post-COVID, when we actually went and visited some of the villages, they played a huge role when it came to sort of managing. At the end of the day, like I'm sure at some of the private hospitals, because we also work closely with them, a lot of these nurses went into attrition. I'm talking about the tertiary care level. But some of these ANMs and ASHAs are the ones who actually help, because they have a huge portfolio. And gone are the days now, I think thanks to at least the southern states, we have now everything is in an app and a tablet. Earlier those were registered. They were the ones. There were little attrition, but they could handle the entire crisis. Some of the other work were actually transferred to them, but actually they could handle the crisis.